Okay. Hi, everyone. I'm René Pareja, Associate Editor of International Journal Gynecological Cancer. And I would like to give you a welcome for today's Journal Club. I'd like to thank ESGO and IJGC for their support in our Journal Club. Arthur, can you please address some housekeeping issues before starting?
Yeah, thank you, Renee. So before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We are recording today's discussion, and the recording will be made publicly available. Participants with cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations. If you're having any difficulties or questions, please send a message in chat and our technical support will assist. We'll have time for Q&A and encourage you to submit questions via the chat function throughout today's session. And with that, I'd like to hand it to Dr. René Pareja. Hi, René, do you have your microphones? Yeah.
Thank you very much. Hi, everyone, and welcome. This month's article is the predictive factors on sentinel lymph node failed mapping in endometrial carcinoma patients, a systematic review and meta-analysis by an Italian research group from Bologna and Gemelli Hospital in Rome. I'm pleased to welcome Dr. Diego Raimondo, Dr. Julia Rovero, and Dr. Francesco Fanfani to join us. Diego, Julia, and Francesco, thank you for being with us today and sharing a deeper insight into this great article. I'm going to hand it over to you for a summation of the article.
Hi, everyone. We thank you for the introduction and for giving us the opportunity to present our article. So next slide, please. Okay, this is the title of our study. Predictive factors of sentinel lymph node failed mapping in endometrial cancer patients, systematic review and meta-analysis. Please, next slide. So, okay, briefly, we start from the clinical evidence that in endometrial carcinoma patients, bilateral sentinel lymph node mapping through the cervical injection of ICG fails in 20 to 25% of cases, leading us to perform standard lymphadenectomy. As you know, several factors can potentially affect the likelihood of detection. However, pooled data about predictive factors of failure are lacking. So a systematic review and meta-analysis was performed, studying, assessing predictive factors of failed sentinel lymph node mapping in apparent uterine confined endometrial cancer patients undergoing sentinel lymph node biopsy through the cervical injection of ICG. Please, next slide. So, the association between failed mapping and predictive factors of failure were assessed, calculating the odds ratio with 95% confident intervals. You can go to the next slide, please. Okay, so coming to the results, 6 studies with a total of more than 1,300 patients were included. Compared with patients with bilateral successful sentinel lymph node mapping, patients with failed mapping showed a significant association with an ICG volume inferior to 3 milliliter, advanced FIGO stages, enlarged lymph nodes, and lymph node involvement. Next slide, please. In conclusion, we demonstrated that a volume of ICG dose inferior to 3 milliliter, advanced FIGO stages, and bulky lymph nodes seem to be good predictive factors of failed sentinel lymph node mapping in endometrial cancer patients. Other supposed factors, such as old age, high BMI, previous surgeries, non-endometrioid histotype, and grade 3 tumors didn't appear associated with mapping failure in our pooled analysis. Thank you.
Thank you for this wonderful summary, Julia. We will now spend the remaining time on answering questions and group discussions. Attendees, we encourage you to submit questions via the chat functions, and we will do our best to address as many as possible. We're going to start out with some questions by our fellows. Andrea Rosati, you're up the first.
Oh, so I'm Arthur, and I'm sorry that Andrea Rosati cannot, he's still in the OR, so I'll do his question. So Diego and Julia, based on the results of this meta-analysis, we should conclude that severe obesity, old age with lymphatic atrophy, retroperitoneal distortion due to previous surgery or radiotherapy, highly aggressive biological tumors, and the presence of ESI do not increase the risk of bilateral mapping failure. So how do you suggest counseling patients with one or a combination of these factors? Do you think we should not anticipate a higher rate of mapping failure and a subsequent higher need for site-specific lymphadenectomy in these subgroups of patients? Thank you.
Thank you, Andrea, and thank you, Arthur, for your question. Actually, yes, we canceled a patient with endometrial cancer scheduled for sentinel node technique, anticipating a possible mapping failure, but especially in those cases that I mentioned before, that Julia mentioned before. Surprisingly, watching our poly data, variables potentially related to an unsuccessful mapping, for example, old age like BMI, as you pointed out, one by one did not show a significant association with this letter, so with the mapping failure. Notably, as you pointed out, a combination of this factor, yes, could impact on bilateral mapping success. Of course, it is an interesting topic to explore that needs further investigation. Thank you.
Thank you so much.
Thank you, Dr. Raimondo. I think we have another question from Nuria Agustin.
Yeah, hello. Thank you for being with us, sharing your thoughts regarding this interesting manuscript. Well, as we all know, there are different sentinel lymph node detection methods used, and such as blue and ditracer, radiotracer, and other combinations of them, other than the indocyanine green. So my question is, why did you only choose to include indocyanine green studies? Thank you.
Thank you, Nuria, for your question. Actually, we focused on ICG studies because nowadays ICG mapping seems to be the most efficient one on clinical practice, with compelling results published by several reports in terms of strong tissue penetration, bilateral detection rates, and a rapid development speed.
Okay, thank you, Julia. We have a question in a chat box. What would you say is the best injection method, location, and amount of ICG? From Melissa Hobbe.
Yeah, thank you, Elisa. Yeah. Well, the best injection method. We explore our study focusing on study that perform the injection in a similar way. So injection through the cervix at 2 points, so 3 and 6 o'clock. And we suggest to inject in a superficial and deep way, preferring the superficial way as focusing also in a consensus by Moloney et al. In your journal. So according to the best practice, yes, it is to perform the injection through the cervix at the 2 points, so bilateral points, and with superficial and deep injection, so a few millimeters and 1 centimeter. And the amount of ICG, according to our study, we prefer to use a volume equal or superior to 3 milliliters. Thank you.
Sorry,
Okay,
just a follow-up if that's okay. 3 millimeters at both points, at 3 and 9 o'clock?
No, 3 milliliter in total. The total volume for the per injection. The first injection, the total volume 3 milliliters, so 1.5 per side.
Okay, and then, sorry, if I may ask a follow-up, I know you guys had commented on the possibility of then maybe re-injecting if you had failed mapping. Could you comment sort of on timing of this approach?
Yeah. This is a tricky question. Yes, of course. We follow the consensus from Moloney et al. So we don't have the perfect exact time. We can spend some time. We prefer to wait 50 minutes before the injection, and we wait for the flushing into the lymphatic channel and the first colored lymph node per side. So our time is 50 minutes. I don't know if Professor Fanfani can say something about this point.
Only a comment about ICG. When we state that we have to inject deep and superficial, we consider the old version of the tracer. Since ICG is a smaller molecule compared to the blue dye, to the technetium, probably the injection can be better in terms of sensibility of detection rate. This study recommended at least 3 milliliter in total, probably because, as you can see in real life, someone can say, I can inject only 1 milliliter for side superficial, and probably in every single institution you can find the notes, but probably you need to recommend how is the minimum level. It seems from that analysis, that is a retrospective analysis, multivariate analysis, that we need to inject more than 3 milliliters. And in particular, I cannot say if there are differences between deep and superficial or only superficial. We have no data to say this type of differentiation.
No, unfortunately not, yes. Only if, according to the volume.
About the reinjection, Diego, when we reinject, and we very trust on the reinjection because we increase the number of bilateral from 75 to 85, 95 bilateral detection rate. I mean, we have to consider only 1 milliliter for side and superficial, because after an injection, go deeper to the previous injection cannot be a good option in our opinion. But it's our opinion, it's not real data, it's not a statistical data.
Thank you, Francesco, for your support and your experience, great experience.
Thank you, Dr. Fanfani. By the way, I'd like to ask a question. Amanda Nichols published about 3 years ago an alternative approach for those who failed a unilateral mapping. And what is to send the uterus for frozen session in order to identify major factors for sparing the lymphadenectomy in the site that was missed. Have you some talks about this approach in order to spare more lymphadenectomies? According to that paper, it's 40% of lymphadenectomies that can be spared.
Yeah, this is a good point. Actually, also Gemelli in Rome and the study by Tortorella speak about this point because, yes, of course, we perform this type of technique to assess lymphatic status, lymph node status, and we have the risk to perform lymphadenectomy also in low-risk patients because we perform this type of technique for all endometrial cancer patients. So in low-risk patients, Yes, we can avoid any lymphatic procedure if we fail with the lymphatic lymph node approach, sentinel lymph node technique. Yeah, Francesco, do you agree with this recommendation? So in low risk patient, we can avoid it.
Low risk patients with high morbidity patients. In case of no morbidity patients, we still perform site-specific lymphadenectomy because we know that 5 to 6% of patients with apparently low risk, low risk only after hysterectomy. You cannot say that it is a low risk because you cannot have LVSI.
Frozen section require good expertise by pathologists.
You cannot have LVSI by frozen section. Probably, if you can have molecular profiling before due to after hysteroscopy and reduce the number of LVSI, you can spare lymphadenectomy. But if you have an obese patients with monolateral or also bilateral failing mapping with low-grade cancer, less than half of myometrial invasion, for sure we will spare lymphadenectomy. But in all the other cases, we still perform a site-specific.
Thank you very much for clarifying this. I think we have another question from Anissa.
Thanks, Renee, and thank you so much to the authors for this wonderful paper. So my question is, can you explain why a 13 kilogram per meter squared BMI cutoff was used? Because data from our previous Memorial Sloan Kettering study showed a significantly lower bilateral sentinel lymph node mapping rate in patients with a BMI of more than 40 kilograms per meter squared using ICG. Perhaps this could explain why the BMI was not associated with failed SLN mapping in this paper. Thank you.
We prefer to divide the patient according to this cutoff, because most of the study, most of the analysis based on this study are performing this type of cutoff, so 30 and not 40. Absolutely, we can fail with this point. We have to improve our analysis for obese patient, because yes, obese patient can have a higher risk of failure, and it is a good suggestion for us. Thank you.
Thank you very much. We have another question from Ryan. Ryan Khan, are you here?
Actually, I could ask
Teresa.
his question, and I would add one of my own, actually. The question of Ryan was about the pathology, because in your analysis, it wasn't described as statistically significant for the outcome, but in other studies it was. So if you could comment on that. And my other question was, do you have any experience about combination of different sentinel mapping methods? Thank you.
Yeah, according to the cervical pathology, maybe Julia can say something.
Yeah, so this is a point that deserves attention, because it is reasonable that anatomical distortion of the cervix could cause by local disease or surgery, could alter lymphatic channels inside the stroma, impacting on the success of the sentinel lymph node mapping via ICG cervical injection. However, our pool data limited to prior cervical surgery didn't support detrimental effect of cervical status on bilateral success rate of sentinel lymph node mapping. Surely, a subgroup analysis considering the impact of each condition affecting the cervix could show different findings. And more data are needed to figure out these aspects, surely.
If I can add a comment about this, in patients with previous conization, there is also a previous paper by Pedro Ramirez and MD Anderson about the fact that the previous conization doesn't impact negatively on the mapping. but they suggest in that case to do only superficial injection, because if you have a real conization, the length of the cervix can be lower. So don't go too much in deeper in order to avoid the risk of entering in the peritoneal surface, because one of the limits of the ICG is that if you are wrong in the injection, all becomes green. So it's very hard to identify the pathways.
Okay, thank you so much, Francesco. I would like to remind to the attendants that we have enough space in the chat box for receiving your questions. I think our next question is coming from Julio.
Yes, thank you, Rene, and thank you, Julia, for the presentation, and to all the authors for the great job. So you mentioned enlarged lymph nodes as a predictive factor of sentinel lymph node failed mapping. In the case of preoperative evidence of enlarged lymph nodes, the studies that you analyzed perform sentinel lymph node mapping or straight lymphadenectomy? And also, what do you know when they perform a para-aortic lymphadenectomy? Thank you.
Thank you, Giulio, for your question. Well, most of the studies included in our meta-analysis followed the NCCN guidelines for nodal assessment in apparent uterine confined endometrial cancer patients, recommending adherence to the Memorial Sloan Kettering SLN algorithm. This algorithm included retroperitoneal evaluation with excision of all mapped sentinel lymph nodes and of any suspicious enlarged lymph nodes, regardless of mapping. Regarding the opportunity to perform or not para-aortic lymphadenectomy in the included studies, this decision was based on a case-by-case selection.
Okay, thank you, Julia.
Okay, I think, Teresa, do you have another question for them?
I actually was still wondering about the combination, if you have ever tried that in your institutions, and thank you for your time.
Yeah, in our institution, Teresa, yeah, we prefer to use only ICG via cervical injection. So we don't have experience with combination of the injection. Maybe Francesco can say something about this.
Combination, you mean ICG and what? Sorry.
And other substances, other contrasts.
But after the film study by Michael Szumowicz, I think that we really know that ICG is the easy, cheaper, best. Is not superior to the combination of blue dye and technetium. Is equal in terms of detection rate, but more safe, faster. We don't need the nuclear medicine in our OR. It's cheaper. No risk of allergic reaction, very low risk. So we don't need to increase the numbers if the number is very high. What we can expect in the future is the combination between ICG and preoperative detection with new tracer that combine PET-CT before surgery in order to know before the surgery where can we find for the mapping.
Thank you.
We are working on that.
Thank you, Francesco. I have a question for you, Francesco.
Yeah.
What is the current rate of failed mapping in your institution right now? And how many additional nodal involvement have you found in those who had failed mapping?
We have bilateral mapping in 85 and at least unilateral in 95%. So we do 15% of site-specific and 5% of bilateral site-specific. But in some cases with failed mapping, if they are obese patients, a high risk of complication, and preoperative low-risk cases, we can avoid the need of lymphadenectomy. So it's not always when we have a failed mapping, because since you consider that you can have a failed in obese patients, old patients. So sometimes after injection or injection, we can consider to avoid the need of lymphadenectomy.
Perfect. Thank you, Francesco. Giuseppe, you have a question. Can you do it by yourself?
Yes. Hello, everyone. Sorry. First of all, thank you and congratulations to all the authors. My question is a more provocative one about the role of the molecular classification and the SLN algorithm and the lymphatic surgery. What's your opinion about the role of this, and if we are ready to modify our practice right now, and what's the future of that? Thank you.
Can I answer if you want, Diego?
Yeah.
Nowadays, there are two studies. One retrospective is the Seneca trial in Europe by Luis Chiva that recorded all patients, and then one prospective, the Eugenie trials by Frederick Amant. We have no data to say that in case of poly, for example, we can spare lymphadenectomy, but we have also no data to say that in case of P53 mutation, we need to perform lymphadenectomy. So we need data to try to tailor staging procedures according to different TGCA subtypes.
Thank you. Thank you very much, Francesco. I think Arthur have a question.
Thank you, Rennie. Diego, do you have any comments about the maximum and minimum time between the cervical injection and the sentinel lymph node procedure? How can it affect the sentinel lymph node mapping procedure?
Yeah.
Thank you.
Thank you, Arthur. Yeah, absolutely. We have talked about it before. We wait 50 minutes to decide to go for reinjection. From the injection to the attempt to see the sentinel node per side. So this is our time. So 50 minutes, the maximum time.
Thank you, Dr. Raimondo. Anissa, I think you have a question for them?
Yes, I wanted to know, I'm going to ask on behalf of Jennifer Davis Oliveira, who's not there, and she asked, what further information do we need to further our knowledge of sentinel lymph node mapping in endometrial cancer?
Sorry, can you repeat? Because I don't see,
what further information do we need to further our knowledge of sentinel lymph node mapping in endometrial cancer?
Okay, thank you. Maybe Julia, can you answer?
Yeah, we think that we have to explore better other technical variables, such as infiltration of the injection, as we mentioned before. Concerning these aspects, unfortunately, we have no granular or raw data from included articles to make statistical analysis. Another limitation of our study, which would be interesting to further investigate, is the impossibility to assess the presence of adipose-only sentinel lymph nodes, also called in literature empty nodes, for example. The evaluation of the specimen at the back table and fast sending of tissue via telematic pathway to the pathologist could improve sentinel lymph node technique performance.
Thank you, Dr. Julia. Who is our next person asking? Jennifer Davis is here.
Anissa asked instead of Jen, I think. I'll be glad to ask my question.
Okay,
if you're not
Okay, Vansa.
against.
Thank you so much, Vansa.
Thank you. Thank you all for the discussion. And my question is, what do you think? Like, how could the clinical practice and approach to the patients with endometrial cancer be changed based on the findings in your analysis?
Always, Julia.
So our findings can allow a more tailored counseling and a more proper surgical planning. We must be aware and counsel the patients that the procedure could fail, especially in cases with lymph node involvement, and the surgeon must be prepared to perform standard lymphadenectomy. In addition, we suggest the use of an ICG volume of at least 3 milliliter, as we said before. And in case of enlarged lymph nodes, we support the ESGO recommendation to remove them and to avoid further procedure, including sentinel lymph node technique. On the other hand, our results suggest that tumor characteristics such as deep myometrial invasion, grade 3 tumors, non-endometrioid histotype, and lymphovascular space invasion seem not to influence sentinel lymph node mapping success. And these findings sustain the use of sentinel lymph node biopsy for surgical staging, even in high-risk endometrial cancer patients.
Thank you very much.
Thank
If
you
you
very
let
much.
me. Actually, it is very, I would like to selfishly thank you for this information, because in our location, it is very difficult for patients. They have to get access to the ICG, and it's very difficult. So it's important that we inform them that there is a risk of failing. And also, I would like to hear your advice about what to do when the patient or we are not able to use ICG for mapping. And what about using just blue dye?
This is a question. So when we have to change from ICG to blue dye, this is the question.
No, actually, my question is sometimes we are our patients have to get access to the material. So for all the patients, we are not able to do the ICG. So what is your advice? What to do when we don't have an ICG for the patient, and should we do with just blue dye the mapping, or should we do?
Yes, absolutely. Yeah.
So in case of no availability of ICG or camera with infrared, use the blue. I think that nowadays the gold standard could be to increase the number of bilateral mapping. Waiting for the data from the Alicia trial, Endo-3 trial, they can change the word, but waiting for this data, reducing the number of nodal removal and increasing the number of detection due to the ultra staging, in the future probably also with some molecular like OSNA, we can have a better stratification for patients. So in case of no ICG, blue dye. This is my option, our option.
Yeah.
Thank you. It's just an inaccessibility issue for our location.
Yes. Because we have to remember that blue dye has a good results, because 60 to 70% of patients were reported with bilateral mapping. Okay. So.
Thanks.
You're saying that
second line.
Doing with blue is better than doing nothing.
Yes, less is more than nothing. Less is more than nothing.
It's a good second line.
Yes, less is more than nothing.
Perfect. Thank you so much. Florencia from Buenos Aires, Argentina, has a question for you.
Hi, thank you, Rene. Congratulations on this great presentation, and thank you for the discussion. My question is, if you detect an unilateral non-specific adenopathy in a preoperative MRI, for example, or a CT scan, but its association cannot be ruled out from the uterine tumor, do you perform sentinel node mapping, or you prefer to go to the complete lymphadenectomy on that side?
If we have adenopathy in the pelvic region, yeah.
Yes, in an MRI preoperative, for example.
Yeah, as the statement say that we have to remove only a larger lymph node, and we can avoid any further procedure on the lymph nodes. Francesco, what is your recommendation about this?
We changed the rule because it's not staging, it's cytoreduction. So normally when we do surgery and we know that there are bulky nodes, we try to perform a systematic pelvic lymphadenectomy, aortic lymphadenectomy. But we know that, as Diego mentioned, that the requirement is to remove the enlarged, like in advanced ovarian cancer, because you are not doing a staging, you are doing a cytoreduction. But because there are no data about the curative effect of non-positive nodal removal, but you never know before removal the nodes in case of bulky, more than one bulky, if the non-bulky are positive or not. So we really trust on systematic pelvic and aortic lymphadenectomy in case of pre or intraoperative detection of bulky nodes.
Okay.
By laparoscopy,
yes.
Either by laparotomy. It depends from the type of bulky, location of bulky.
Okay, great. So
patients.
You have less than 1 centimeter, but in a specific, suspicious, in the middle, adenopathy, unilateral, you perform the complete lymphadenectomy. Or
in that case, we do. We cannot do mapping because in case of suspicious nodes, mapping is not allowed. In the algorithm, you need to have no positive nodes at the pre and the intraoperative detection. So in that case, we remove the bulky, we send for frozen section, negative, we stop the surgery from this in this side, and in cases positive, we try to perform systematic pelvic and aortic lymphadenectomy.
Okay, thank you. Thank you so much.
Thank you very much. Melissa, do you want to make your question on the microphone, please?
Sure. It's not really a question, more sort of a personal dilemma I often struggle with in patients who have high-risk histology, like serous or carcinosarc who have failed mapping. I often, ethically am asking myself the utility of a full site-specific lymphadenopathy in a patient who I know is going to have adjuvant therapy with chemotherapy, for example. Just wondering what your experiences are, thoughts are with negative preoperative imaging and a failed mapping and a high-risk histology. Sort of what is your approach? Is it still site-specific lymphadenopathy?
If we fail in
high risk, yes.
Yeah.
We follow the algorithm in low risk and high risk. We know that the new molecular classification is not still new, is the standard molecular classification can lead us to use or not adjuvant therapy. Now we are looking for new adjuvant therapy in the future. So for sure, we can consider the option, but to date, we have no data to spare lymphadenectomy, in my opinion, also in high risk in case of failing mapping. Also, if we know that that patient will undergo 2 adjuvant chemo and radio, for example.
Okay, thank you very much. Francesco, I'll make a political question.
To Diego, not for me, not to me, to Diego.
To Julia.
To Julia, because Julia, you cannot do
Francesco,
unpolitically.
Yes.
Yes.
I think this question is for the professor.
No, I'm not.
If ESGO guidelines states that sentinel node detection alone is not the standard in endometrial cancer, and they still recommend to perform pelvic lymphadenectomy. This policy of performing isolated sentinel node detections is just in research protocol projects, or is an institutional decisions in the participant institutions?
If I remember well, the ESGO guidelines consider sentinel node as an alternative to pelvic and aortic lymphadenectomy.
Yeah.
So we can say that according to your internal vision, you can say we perform only sentinel node, also in high risk or not. But it's an alternative, it's not a research approach, it's not also away from the trial. They consider sentinel node in low risk as an alternative, nothing, and in high risk, sentinel or full pelvic and aortic.
Yes.
Okay. Thank you,
In
Francesco.
case of patients with negative preoperative imaging.
Imaging, yeah. Without evidence of nodal disease.
One of the problem is that ESGO guidelines recommend CT or MRI or PET-CT only for detection of nodes. So the real question, do we need always CT or MRI in all uterine cancer? In high risk, for sure. We normally do in high risk always a CT.
Perfect. Thank you very much. I think we have time for a final question. Arthur, can you do your question, please?
Okay, thank you. My question is that Glaucobiology published that MMR deficiency more easily disseminates to the lymph node. So he proposed in Joint Oncology that when a mapped hemipelvis, grade 1 or 2, or myometrial less than 50%, if MMR proficient, no further lymphadenectomy. But if MMR deficient, do a site-specific lymphadenectomy. Do you have any thoughts on this? Thank you.
So if you can repeat, because I don't hear very well the question, sorry.
Okay, I've also put it in the chat box. So
yeah, I can answer if you want.
Okay.
Thank you so much.
I think that this sub-analysis by Glauco Baiocchi is a good way to try to modulate, to tailor the surgery. But we need more relevant data, huge data. I think that the Eugene trial that is now ongoing in Europe, and we hope to spread also in the US or in South America, about the real need of staging, not only for nodal, but also for peritoneal staging according to TGCA. I cannot remember the exact number of patients, but I remember it's a very low number of patients in this paper. So it is not conclusive, in my opinion.
Thank you so much.
Rene, you are muted.
Thank you for your answer, Francesco. I would like to thank all of you. This journal club has been very insightful, and we hope you enjoyed the time with us today. I want to again thank to Dr. Diego, Julia, and Professor Francesco Fanfani, and all the faculty for their time. I would like to thank all of you for attending this journal club. The recording to today's session will be available on the IGCS, IJGC, and ESGO website. Please remember to join us at July for our lead article in long-term survival outcomes in high-risk endometrial cancer patients undergoing sentinel lymph node biopsy alone versus lymphadenectomy. Goodbye, and thank you very much. Have a great rest of the day, afternoon, or night.
Bye-bye.
Thank you. Bye.
Thank you.
Thank you.
Bye-bye.
Thank you. Bye.